نوفارت السيمبوزيوم. خلاص احنا جوعنا، خلاص اخر حاجه هي هيبقى معانا فيها تو سبيكرز، خان تركش يس هيكلمنا على نيو جايد لاينز ايفوليوشن فروم ايفيدنس تو كلينيكال براكتس. اتفضل دكتور خان.
Before starting my speech, I would like to thank to the organizing committee and the Novartis company for inviting me for this excellent symposium. And dear chairman and my colleagues and my friends, I am saluting all of you from here. Now I will talk to you about the evolution of GOLD guideline a little bit, not getting into so much details. As you know, GOLD Society was established in 1998 and the first guideline was released in 2001. Starting from 2001, between 2011, we can't say that so many changes occurred in the guideline, so we call this guideline in 10 years as the classical one, but some major changes happened in 2011, some minor changes happened in 2013, again minor changes in 2014, 2015, and some major changes happened in 2017. If we start with the 2011 revision, as you know, the GOLD guideline has 6 chapters, and the major things are happening in the chapter 2, 3, and 4, which are the diagnosis and assessment, therapeutic options, and the management of the stable COPD. If you start with the COPD diagnosis, GOLD always asks the clinicians to have the symptoms first and or the a history of exposure to the risk factors. In 2011, GOLD committees appreciate that sometimes having an exposure history might be difficult, so the patients, if have classical symptoms, should not be withheld from the COPD diagnosis. So we just put here and or statement. First, the symptoms and or the presence of exposure to risk factor history. And also, since the establishment of GOLD Society, we had 2 main aims. These were first the reduction of symptoms, and the second one was the reduction of the risk. Under these headlines, we have relieving symptoms, improving exercise tolerance, improving health status, preventing disease progression, and preventing and treating the exacerbations, and reducing the mortality rates. Before 2011, we have only 2-dimensional assessment system for COPD patients. This was done according to the post-bronchodilator FEV1 values. According to this system, while the FEV1 is falling down, disease is progressing and the symptoms are increasing. However, and patients were classified according to their post-bronchodilator FEV1 values, according to mild COPD patients, moderate COPD patients, severe COPD patients, and very severe COPD patients, and these patients were treated accordingly. In mild and moderate COPD patients were treated with bronchodilators mainly. In severe COPD patients, if there are repeated exacerbations, inhaled corticosteroids were included, and in very severe stage, we had some other additional treatments like long-term oxygen treatment, nocturnal oxygen treatment, non-invasive mechanical ventilation, and some lung volume reduction strategies using the bronchoscopy and surgical methods. However, this was abandoned in 2011, and 2011 we just passed to switch to a new assessment system. We called it as 3-dimensional assessment system, or the combined assessment system. In this assessment system, we ask the clinicians to evaluate the patients according to their risk, if they are high-risk patients or low-risk patients, according to the exacerbation history in the last 12 months, and the post-bronchodilator FEV1, whether it is more than 50% or less than 50%. In the risk assessment, we use both exacerbation history and the post-bronchodilator FEV1, and we choose the worst one. So we should use both of them for evaluation, and we should choose the worst one. For the symptom assessment, we had MMRC and CAT scoring systems. If MMRC is less than 2 and CAT is less than 10, these patients were evaluated as the less symptom patients, and then patients were categorized A category, B, C, and D category COPD patients with this risk assessments and the symptom assessments. For the first time, GOLD just gave us a new pharmacological management system. They just used recommended first choice and alternative choice treatment for each categories, A, B, C, D categories. Mainly for A and B categories, the main system was the bronchodilators, short and long-acting ones, and their combinations. And C and D categories, the first choice treatment was ICS-LABA combinations for C and D categories. And something happened some new changes happened in 2013 update again. And these changes mainly happened in the COPD diagnosis. Some changes happened in the quality of life assessments. Some changes happened in the assessment of COPD, and some changes occurred in the treatment strategies. If we start with the COPD diagnosis, as we said, once GOLD was asking that the first symptoms should be present and or a history of exposure to risk factors, and GOLD changed its mind in 2013, and we just excluded and we just put and. So GOLD just decided that the symptoms and the history of exposure to risk factors should be present in the same patients to make the diagnosis. This was the decision made in 2013 update. Also, some changes happened in assessment of symptoms. According to these changes, as you know, for the symptom assessment, we were using MMRC and CAT scoring systems. A new alternative was included into the list. This is the clinical COPD questionnaire. This questionnaire has, if the questionnaire score was equal to 1 or less than 1, and these patients were evaluated as less symptom patients. If the score is more than 1, and these patients were evaluated as more symptom patients. CCQ questionnaire or clinical COPD questionnaire has 10 items, and each item is scored from 0 to 6. Then we sum all these question scores, and when we obtain the total score, we just divide the total score into the number of the questions, which is 10. Then we get the average score for each patient. So the CCQ scoring was included in the list as an alternative to MMRC and CAT scoring systems. And also the risk of exacerbations again changed. Some new studies has clearly shown that only one hospital admission may increase the risk of death 3 or 4 times in long-term follow-up. And so GOLD committees bought this approach, and they just decided that you don't need to wait 2 exacerbations in 1 year, in the last year, and if there's only 1 hospitalization, it is enough to assess these patients as a high-risk patients. And this hospitalization history was included in the right side of the ABCD category system. And some new changes also happened in 2013 guideline. In this guide for the treatment, for the first time for category D patients, ICS LABA-LAMA treatment, in other words, triple treatment was recommended as the first choice. And the second choice treatments for the category C patients, LABA plus PDE4 inhibitors and LAMA plus PDE4 inhibitors were included. And another one, ICS LABA combination, was excluded from the treatment recommendations because there is no study or there is no evidence with this combination, although we know that it's a quite effective combination in COPD patients. Some new drugs included in the list. These are the long-acting antimuscarinic agents, aclidinium bromide, which is 12-hour acting, twice daily anticholinergic agent, and glucopronium bromide, which is a 24-hour acting, twice daily antimuscarinic agent included in the list. So this is the clear form of the treatment recommendations for 2013. Also, some new changes happened in 2014 update. Exacerbation treatment changed, and the ECOS chapter was included with the collaboration of GINA and GOLD representatives for 1 year. It was included in both GINA and GOLD guidelines, and some new drugs in the drug list. We'll see. According to the study done by Leupe et al. In Switzerland, they just compared 5-day systemic corticosteroid treatment with 15-day corticosteroid treatment in the treatment of exacerbations, and they have found that there is no difference regarding the efficacy of these two drug regimens. There is no difference between giving 5-day treatment and 15-day treatment in these patients. They did not find any difference between the hospitalization rates, mortality rates, FEV1 values in the next 6 months follow-up. And the GOLD bought this study results too, and now GOLD is recommending that the exacerbations in COPD patients must be treated with 5 to 7 day 30 to 40 milligram methylprednisolone, not 15 days. Only 5 to 7 days is enough. And if you think that these are old people, these are immobile, these patients have cardiac problems, these patients have hypertension, these patients have diabetes mellitus, and these patients have osteoporosis, this recommendation is quite reasonable. And we should not forget one more important fact, that indeed majority of the adverse effects of corticosteroids happen on a cumulative basis. In other words, the total dose, lifelong taken total dose, the most important determinant for the occurrence of adverse events. Yes. And also, as I said, ECOS chapter was included in the list in GOLD guideline and GINA guideline. As we all know, sometimes it may be really very difficult to distinguish between asthmatic and COPD patients, or both of them sometimes can exist together. A stepwise approach was advised by GOLD and GINA. This approach system included comprising the recognition of the presence of a chronic lung disease, and the categorization as asthma, COPD, or the overlap syndrome between. And then the confirmation by spirometry is necessary, and then, if necessary, referral for specialized investigations was advised by GOLD and GINA. And this flow chart includes, first we must make that we are facing with a chronic airway disease. Then we have some classical asthmatic and COPD features. We are checking those features for any given patient for asthmatic characteristics and the COPD characteristics. If the asthmatic characteristics are dominating, so it's a patient with asthma. If the COPD characteristics are dominating, it's a patient with COPD. But if the characteristics are 4 characteristics for asthma, 5 characteristics for COPD, so this is an ECOS case. If the 5 characteristics for COPD, 6 characteristics for asthma, or 4 here, 3 here, or 3 here, 4 here. So if the characteristics are, number of characteristics are close to each other, it's probably a patient with ECOS, asthma, COPD overlap syndrome. And we should not forget another fact, that post-bronchodilator FEV1 over FVC ratio is usually less than 0.7 in these patients. And GOLD recommends the treatment of these patients with ICS LABA on the first hand, and if necessary, another LAMA can be added over. And if we are facing with a very complicated patient, this time referral of these patients to a specialized center is recommended. And some new drugs were included in the list. For the first time, once daily 24-hour acting ICS LABA combination was included in the list, vilanterol fluticasone combination, as you see here. In GOLD 2015 update, Wisdom trial made a good, great impact on this GOLD 2015 update. Wisdom trial revealed that in patients with severe and very severe COPD, inhaled corticosteroids could be withdrawn gradually over a 3-month period without increasing the medium-term risk of exacerbations, although lung function deteriorated significantly in these patients. Wisdom study design is like this. In the beginning, we had 2 treatment arms. The first arm remained on ICS LAMA treatment from the start till the end of the study, and in the second arm, in 18 weeks, the corticosteroid was withdrawn from the treatment in a stepwise manner. After the 18 months, this second arm received only tiotropium and salmeterol drugs. And then the patients were followed up for 52 weeks. At the end of the study, we couldn't see any difference between the groups regarding the exacerbation rates. However, especially in the first 18 weeks, there is a sharp drop in FEV1 in the ICG withdrawal group. There was another further 5 milliliter decrease in FEV1 until the end of the study. And in total, when we compare with the other triple arm regimen group, there is a 43 milliliter decrease in the ICS LABA group. However, this condition did not affect their dyspnea perception, and this condition did not affect their St. George Respiratory Questionnaire scorings in a clinical in clinical terms. Also, there were some minor revisions in GOLD 2015. Shuttles, they said that shuttles in walking tests should not be shorter than 30 meters. Sildenafil use has no benefit for physical activity and pulmonary rehabilitation. On contrary, it might lead to an increase in pulmonary artery pressure. In general terms, not on a patient basis, on a specific patient basis, of course. Vitamin D has no role in COPD treatment, and the beneficial effects of long-term NIV on quality of life and mortality are not clear. Positive influence of integrated care systems could not be shown yet, and also a very strong anti-hyperlipidemic drug, simvastatin use has no benefit on exacerbations and mortality in COPD. I believe the last statement about the gastroesophageal reflux disease is very important, because it was found that it is present in 30% of COPD patients, and also it leads to an increased rate of exacerbations for 40%. If there is a gastroesophageal reflux disease in a COPD patients, they will experience 40% more exacerbations, and the St. George Respiratory Questionnaire in these patients are 3.4 units worse. So what we should learn from this statement is that we should ask all our patients about gastroesophageal reflux disease, and if it is present, it should be treated actively. Otherwise, you will have more exacerbations and worse quality of life in COPD patients with GERD. And also, some new drugs included indecoterol glucopronium, which is a once daily 24-hour acting LABA-LAMA combination for the first time, vilanterol umeclidinium, which is again 24-hour once daily in the LABA-LAMA combination, and these were included in the 2015 drug list of GOLD recommendations. GOLD 2017 revision was released on November 16, 2016 on World COPD Day in Philadelphia, and our new slogan was "Breath in the Knowledge." It is still acceptable even today, and our older one was "It's not too late." Just to remind you, in this 2017 GOLD guideline, first of all, the definition of COPD has changed. We just excluded the progressive part and the enhanced chronic inflammation part from the definition. We just let persistent respiratory symptoms to stay in the definition. Also, airways and the lungs were excluded, and airways and or alveolar abnormalities were included. Also, exacerbations exacerbations and comorbidities part were excluded from the old definition, and we have the new definition like this one. But exacerbation definition became quite acceptable, and I believe it is almost perfect. It is the shortest one, it is the simpler one, it is very easy to understand now. It also changed in GOLD 2017 update. In the diagnosis, something very interesting happened. If you remember, until 2013, here it was and/or, and in 2013 it was changed as and now in 2017 again it became and/or. And GOLD committee just appreciated that sometimes getting exposure history might be very difficult, and in these patients, if the symptoms are quite classical for COPD, the diagnosis of COPD should not be withheld, and those patients should be treated as COPD patients. As we remember, until 2017, starting from 2011, we had a assessment system for the symptoms, which were including the exacerbation history and the post-bronchodilator FEV1 values in 2000. And according to this system, we had bronchodilators in the A and B categories and ICS-LAMA combinations as the first choice treatment in C and D categories. But in 2017, post-bronchodilator FEV1 was excluded from the categorization system. Now, when we are deciding the risk of the patients, we are only using the exacerbation history, both of them. Either we should use the total number of exacerbations in the last year, or whether there is at least one hospitalization in the last year. These patients are categorized as risky patients. Now we are not using post-bronchodilator FEV1 values while we are deciding the treatment of COPD patients. However, FEV1 is still important, as you know. It is important in the diagnosis, it is important in the prognosis, it is important for the assessment and follow-up and to determine some non-pharmacological treatment modalities, and also it is important for the detection of rapidly declining patients. The main data came from the court study. Why we excluded FEV1 from the risk assessment system is that this study clearly has shown that the FEV1 alone does not reflect the future exacerbations in any patient. If you exclude the exacerbations and if you categorize the COPD patients according to FEV1 values, there was no difference between the exacerbation rates. So FEV1 was excluded from the system, and it's not used anymore while we are deciding what kind of treatment our COPD patients will take. FLAME study made a great impact on 2017 guideline. This study was supported by the Novartis company. I am also one of the centers of this study. And in this study, for 1 year, indacaterol glucopronium combination was directly compared with salmeterol fluticasone combination. The patients were in category B and D patients, and the patients had at least one exacerbation history in the last year. When the study was completed, it was clearly seen that the indacaterol glucopronium combination reduced the exacerbation risk for 16% in all exacerbations, 22% in moderate or severe exacerbations, and 19% reduced the risk in severe exacerbations, and all of them are statistically significant compared to salmeterol fluticasone combination. Also, we have seen the same improvement in trough FEV1 values when compared with the salmeterol fluticasone combination. Indacaterol glucopronium combination once daily improved the trough FEV1 values for 62 milliliters. We have seen the same improvement in St. George Respiratory Questionnaire starting from the 12th week till the end of the study, 52 weeks, and the differences between indecaterol glycopropionium once daily combination and the salmeterol fluticasone twice daily combination are statistically significant, and indecaterol glycopropionium combination improved the quality of life measurements statistically significantly better than the salmeterol fluticasone combination. And if we look at the adverse events, we don't see any difference between the adverse events between indecaterol glycopropionium combination and salmeterol fluticasone combination, except pneumonia rates. We had a significantly higher pneumonia rates in the salmeterol fluticasone combination in the FLAME study. So, bronchodilators are everywhere. In the beginning, bronchodilators are were only group A and B patients, the primary treatment, but now it has become the primary treatment in category C and D patients too. So GOLD just recommend that if a patient comes to you with COPD, on the first hand, we must always think about the bronchodilators, maybe their combinations. And some new drugs included in the list: formoterol aclidinium and formoterol glycopropionium combinations, LABA-LAMA combinations. These are new ones. These are 12-hour acting, twice daily combinations, and olodaterol plus tiotropium combination. It is 24-hour acting, once daily combination, LABA-LAMA combination. In 2018, indeed, no major change. And this version was introduced November 15 in Philadelphia. Our new slogan is the many faces of COPD for 2018. Maybe there is only one change, to tell the truth. If you remember, once it was written here only exacerbation history, it was a little bit confusing. Is it mild exacerbations, moderate exacerbations, or severe exacerbations? Indeed, if you read the guideline, you were seeing that it is only moderate and severe exacerbations. But just to clear the confusion, GOLD included here moderate and severe statement in the main algorithm. So now we know that they are moderate and severe exacerbations while we are assessing our patients for the treatment. Thank you. This is my presentation. If you have questions and contributions.
Thank you very much, Professor Hakan. Professor Hakan is a member of the board of directors of the COPD working group and COPD-related activities, representative and board member of the World COPD Association GOLD in Turkey. On behalf of the Egyptian Scientific Society of Bronchology, it is our honor to present a small memorial for appreciating your coming and sharing our commitments. Thank you very much.
Thank you so much. Thank you so much. Thank you. Any comments, questions?
Any questions? Professor Hussein, Dr. Hussein, تفضل.
Thank you very much for revising the evolution of GOLD guideline. But actually, as a pulmonologist, we are not agree so much for these fast changes almost within 2 to 3 years. We are clinicians. We have our own mind. And the guideline applied in one country should not be necessary to be applied to another country. And now we are in the era of personalized medicine. So I think that it's better to tailoring the medication according to the patient. Every patient is a separate entity. So the physician is the only one who can decide which protocol of medication can be given for this patient. Thank you.
Yes, I agree. GOLD guideline also recommends the tailored treatment, I mean the specific treatment to each patient. We should consider many effects and many features of the patients. They may, those patients may have eosinophilic patients. Those patients may have patients with ACOS. Those patients may have some other features. So these are general recommendations. Of course, specific treatment will be given with the judgment of the clinician. You're right. Thank you.
Thank you, Professor Hakan. Now it is our honor to introduce Professor Eric Pittman from South Africa. Professor Pittman is the founder of the University of Cape Town Lung Institute. He is a full-time director at the institute and emeritus professor and honorary life fellow of University of Cape Town. Professor Pittman was one of the board of GINA more than 10 years. Professor Pittman will speak today about navigation, severe allergic asthma, unmet needs, a central role of for the IgE.
Thank you very much. It's a great honor to be here back in Egypt, and I want to thank the organizers and Novartis for making it possible for me to visit here to talk about one of my favorite subjects, which is how can we better treat patients with severe asthma. I show here a picture of my city where I live. We're having summer at the moment, so it's much warmer than it is in Cairo. So I'm going to talk a little bit about, first, what is severe asthma, what is allergic asthma, because there are changes around the definitions of allergic asthma. I'm going to talk a bit about personalized medicine and diagnosis, phenotyping, and treatments. Then I'm going to talk about the role of allergy and IgE. And lastly, the insights we have received from treating with anti-IgE medications, which really was a very significant advance in the management of severe asthma. So let's deal first with the definition of severe asthma. And I like the ATS-ERS task force. I was a member of that task force, and we divided severe asthma into problematic asthma, which is what faces us as clinicians, and, beg your pardon, can we get it back on? So, let me go back. And treatment refractory asthma, which is where patients' asthma does not respond as we expect it should to the treatments that we used. So the obvious reasons for problematic asthma is you've made the wrong diagnosis, or there are factors that are aggravating the asthma, so-called comorbidities, or non-adherence and poor inhaler technique, or else the doctor who has been treating it has perhaps not been using modern medications in the right way. So it could be a doctor issue. But true treatment refractory asthma is asthma that remains uncontrolled in spite of good first-line treatment. And by first-line treatment, we mean moderate to high-dose inhaled steroids with an additional controller medication. And that controller is usually a long-acting beta agonist, or it may be montelukast or theophylline. Why 2 drugs? Well, we know that a lot of problematic asthma will respond to 2 controller medications where it didn't respond to 1. And these patients are also often receiving frequent or continuous treatment with oral corticosteroids. So that's an important point in the diagnosis and definition. So first of all, wrong diagnosis. And I thought I'd show this slide, which shows 2 different cohorts from different parts of the United Kingdom, in which they found a lot of the patients who came with so-called problem asthma had bronchiectasis, dysfunctional breathing, vocal cord dysfunction, COPD, or one of these other diagnoses that you see listed. How common is true refractory asthma? So if we take the definition that refractory asthma is asthma that's uncontrolled on a LABA plus ICS. If one takes a population like the Dutch population, this is from the Netherlands, Then they calculated there's 6 million people in the Netherlands. About 3% of them have asthma, and they found that 25% of adults with asthma were on a LABA plus an ICS. But when they assessed these patients more carefully for whether they were taking their medications, meaning adherence, or whether they were taking their inhalers correctly, they found that almost 3/4 of those patients were not doing it correctly. So the true prevalence of severe asthma was thought to be about 3 or 4%. So that is true refractory asthma, maybe about 3, 4, 5% of the general population. Other estimates suggest that it may be more like 10% of patients with asthma in the adult category have severe asthma. Now, what about the comorbidities? I think this is very important. But what is important is not just so much that we as clinicians must go through this list and consider these factors as aggravating factors, but we need to bear in mind that they are partially modifiable, meaning we can improve the patient if we address them. But for me, the more important thing is that fixing these things alone does not convert them into being a non-problematic asthma. They may still remain highly uncontrolled. So my experience is I spend a lot of time on the psychological aspects, treating the rhinitis, looking for vocal cord dysfunction, stopping smoking, addressing obesity, but the patients still need their medications. This is not instead of, it's in addition to usual treatment. So you're all familiar with the GINA steps of treatment, and I'm sure in Egypt you have your own guidelines as to how to progress from treatment for milder stages of asthma, step 1 and 2, going through to step 3, which is where most patients with asthma can be effectively treated. But then we get to the patients on step 4 and step 5. So these are the patients who, by definition, if they're not controlled on step 4 or step 5, they have severe asthma. And our therapeutic options in patients like this become fewer and fewer. There are fewer things we can do to address this 10% or so of patients. And what do we tend to do? Well, according to GINA, we add extra medications. So we may add montelukast to the LABA. We may add theophylline. We may start to think of using oral corticosteroids. We need to step up. Unfortunately, often we stick at that stage and forget that the new treatments we're developing are in fact developing specifically for stage 4 and stage 5 patients. And we'll talk about that shortly. Now, when one looks at the whole population, for instance, here in New Zealand, in this study, you can see that about a third of patients, 35%, had ever had asthma. And most of those patients were classified as atopic or allergic. So what does that tell us? It tells us amongst the adult population, children and adults with asthma, almost all of them have an allergic component. Allergic asthma is a very common feature. Allergy is a very common feature in asthma. And I want you to look further down about the incompletely reversible airflow obstruction. You'll see that most of the patients with fixed airflow obstruction, with the most severe categories of asthma, also have allergic feature, or they fall within the allergic asthma group. So let's talk about what is allergic asthma and what about so-called phenotyping, which we hear so much about at international conferences. Well, diagnosing allergy is not a difficult task. It's relatively easy if you take a good history of exposures. Patients tell you the things that cause their asthma to go worse. And if they're allergic triggers like house dust mite, seasonal pollen, then we have a strong lead. If there's allergic rhinitis, that's a very strong lead. If there's evidence, objective evidence of skin prick positivity. Now, we do that routinely in my clinic on every patient who comes for assessment with asthma. We will test for skin prick sensitivity because it's a highly reproducible and a highly sensitive test for allergies. But one could also do specific IgE with arrests. A high total serum IgE is important. Now, in your country and mine, where parasites are common, the levels tend to be higher than it would be in other countries without parasitic infections. However, it's still an indicator in the right context of a patient with atopy. And of course, childhood onset, because atopy usually begins and manifests in early age group. What about the other biomarkers? We hear a lot about blood eosinophils, sputum eosinophils, periostin, and the likes. Well, these, you will see as I show you, are often also elevated in patients with allergic asthma. But we don't use them directly for categorizing patients with allergic asthma. Now, 1970, almost more than 50 years ago, in fact, it was about 67, IgE was discovered. And its original name was the rheogenic factor, or the atopic factor. It was recognized that this antibody played a key role in the manifestation of allergies. Now, we all learned that, and it is an old discovery 50 years ago. So there's an antigen binding site where specific antigens will bind. And within a few years, by 1972, they had recognized that the levels of IgE correlated very much with the risk for developing asthma. And you can see in this slide that atopy, as serum antibodies go up, the titers, the risk of an atopic disease and specifically severe asthma is very common. And you can see that in the UBioPred a series of patients. You can see the majority had features of atopy, and you can see the IgE levels there. They weren't very high. They were about 120 as a mean in severe asthma. Now, in my country, it would tend to be higher than that in severe asthma, but nonetheless, you get the idea. There's a correlation with the levels of IgE. So what does IgE mediate? Well, you all know this cartoon very well. You know that IgE attaches to mast cells and basophils, but also to other cells. They all have high affinity and low affinity receptors for IgE, and when they encounter an allergen, you can see the degranulation that occurs of the mast cell, releasing the immediate bronchospastic reaction. So you're all familiar with this as the key mechanism. Now, 15 years ago, we thought this was the only thing that happened in allergic asthma. But of course, our knowledge has progressed, and we have a much better concept of what else goes on. So the phenotype, if we want to call it that, of allergic asthma is not a simple phenotype, but it's a complex phenotype. It overlaps with other mechanisms. So we learned once sputum eosinophils started to be measured that some patients have eosinophilic bronchial sputum and others had mixed cellularity, some mainly neutrophils, and some have very few cells. How do those eosinophils get there? Well, there are several mechanisms. Now, the one involves the IgE that we've been talking about. So in response to allergens, the processing of allergens by dendritic cells through Th2 mediation, we have releases of IL-9 cytokines that increase mast cell numbers, but we also have IL-4 and 13, which stimulate the development in B cells of IgE production. So the Th2 mechanism is quite important in the development of allergic asthma. But if one looks at other mechanisms, you can see that eosinophils can arise in the airways through other mechanisms that don't necessarily directly result from an IgE-mediated activity. In fact, that usually is through the IL-2 lymphocytes, but the same cytokines are involved. So we have IL-13, which reflects eosinophil presence, IL-4, 13, and IL-5, which is another indicator, important cytokine. And so what has been the evolution of the concept of allergic asthma? Well, years ago, it was allergic versus non-allergic. We used skin prick tests or the RAST or the total IgE plus the other things I've shown you, and that's how we viewed asthma. We started to recognize that there was eosinophilic and non-eosinophilic asthma, and now we call it Th2 high or Th2 low, based upon the presence of different biomarkers, IL-5, 4, 13, periostin, and eosinophils. And a lot of the new treatments that are being developed are then focusing on eosinophilic asthma. Now, what I want to point out is that you can see from this that although we use the word endotype as though we know what's happening when there's eosinophils in the sputum, what we need to recognize, they could get there purely through the IgE mechanism and be part of allergic asthma. Or they may be a more complex endotype in which several of these pathways may work together in causing disease. And in fact, IgE itself is able to trigger the presence of eosinophils, elevated FeNO, and periostin. All of them, by different cytokines, may generate the same thing. So it's not allergic asthma or other mechanisms. Often there's a complex mechanism. Now, omalizumab I'm going to talk about because it was quite a revolutionary development. In more than 15 years ago, omalizumab was discovered, or rather manufactured, as a humanized monoclonal antibody against free IgE in the blood. And what was remarkable is that it was so far in advance of its time. It's been 15 years, taken us much longer to develop anti-IL-4s, anti-IL-5, anti-IL-13s, and to see what they do. But in the meantime, anti-IgE has cemented its place as a very important additional medication. And how does it work? Well, it mops up and binds IgE in the blood so that 3 or 4 molecules will bind to IgE and will form complexes that then get released, and so it prevents allergens from binding to mast cells and other inflammatory cells and prevents asthma attacks. And here is a graph of what happens to free IgE when you give injections of omalizumab. You can see the values drop because they're in complexes, and they stay low until the treatment is stopped. So it's a highly effective way of mopping up that excess IgE. And as a consequence, and not surprisingly, eosinophils reduce in the sputum and indeed in the tissues. But what's important to us as clinicians are the tissue effects, rather the clinical effects. And the two that are most important and for which we give it are predominantly asthma exacerbations and reducing oral corticosteroid use because of their very destructive long-term results. I always like to say when I talk about severe asthma that when I took over the pulmonary division in my hospital, a tertiary hospital, I had a very big clinic of elderly people whose backs were bowed because of osteoporosis, whose bony problems were worse than their asthma. And they all looked like COPD because they had fixed airflow obstruction and it was severe. This has been transformed by modern treatment. So we should not expect that. So the overuse of oral corticosteroids, particularly in countries in which we rely heavily on oral corticosteroids, is a devastatingly bad treatment. And it should be something we should be targeting systematically. Of course, we're also looking for improvements in lung function and quality of life. So I'm not going to show you lots of slides of the studies, the research on omalizumab, because that tends to be boring. But let me just show you a few as illustrations. You can see an almost halving of exacerbations, severe exacerbations in these two pivotal studies. Here's a table showing in children at the bottom, at the top, and adults in the bottom. You can see the sort of percentage reductions in exacerbations, more than 50% in some of them, and not quite as high in others, but all highly significant. Here's an example of reducing oral corticosteroids after 32 weeks of treatment. In one study, you can see that about a 45% reduction in oral steroid use in those patients who were on oral steroids, and you can see that 60% of patients were able to stop their oral corticosteroids. Very important result. And here's a sort of summary cartoon showing you oral corticosteroid reductions or discontinuations, and even inhaled corticosteroid reductions. One can step back treatment with when one has effective control with omalizumab. Here are some studies, 4 different studies looking at quality of life, not as impressive, although in my clinical experience I've seen very dramatic improvements in quality of life in my patients when they've started treatment. So just a few practical questions, because I always get asked the difficult questions about who should receive it, who should I be thinking of? Well, essentially it's people with severe allergic asthma. So that means they're probably on step 4 treatment, on a LABA plus an ICS, or maybe on some other controller. They have features of allergy, and I've explained those. Usually they're fairly symptomatic most of the time. They have evidence of being sensitized to aeroallergens, and in most indications one prefers to get objective evidence of sensitization. We use a total IgE, and we look at a RAST or in the skin prick test. Many of these patients have reduced lung function, but that's not essential because these severe patients, almost all of them, have impaired lung function. They need serum IgE in a particular range. If it's very low, it's probably not indicated. If it's very high, there are technical reasons why that contraindicates use. And often I consider other allergic diseases, because in patients who have severe rhinitis or atopic skin diseases, it will be another consideration for starting it. Now, I'm not going to take you through the details of official indications, but I'm going to touch on just 1 or 2 things. In the United Kingdom, they recommend it for 6 years and older, as an add-on to treatment initially, because you don't stop the other treatments, you add it on and then take away the other treatments as the patient improves. It is patients, they like patients to have at least 4 courses of oral corticosteroids in the year preceding it. So frequent exacerbators would be required. In my own country, they don't specify quite as detailed as that. It's add-on. Positive skin prick test or RAST is required. Impaired lung function is desired. Frequent exacerbations and background treatment. But in children, the indications are more relaxed, because in fact these children need not go on to many treatments before they have omalizumab. It's better to start it earlier, particularly in young children, because they have a dramatic response. Now, I don't expect you to read this chart, but it just tells you that the 2 things we consider in choosing the dose is the body weight and the level of baseline IgE. And the dose is determined according to that. We can talk about that. But a key question people ask me is, how do we know that the patient is responding, and how long do we wait? Well, the standard view is that we need 16 weeks of treatment, 12 to 16 minimum, in order to see an effect, to an optimal effect. But at that point, the physician's assessment based on a careful history is the most important thing. Now, there's this thing called the physician's global evaluation treatment, which can be a test which can be used, which is a composite of lung function, quality of life, and symptoms. And if the patient has a complete or a significant improvement or marked improvement, then you know that the treatment is really working. Now, I would need to sit with you to talk you through how we assess that. But I need to make one important point, because I've been talking to doctors from Egypt, and a lot of them have told me our problem is the patients don't come back, or we may not see them. It is very important that patients are followed up properly. And secondly, that you make a careful documentation, that you write in your notes exactly how symptomatic they were when they start, because they forget how bad they were. And you need to reinforce that by taking a really good history, and I could take you through the things that we use when we do that. But the important point is omalizumab is viewed as a long-term treatment. We expect it to be used for a long time. So how do we monitor effect? Well, we look at the GEAT, we look at lifestyle, asking questions, we look at nasal symptoms. Often the improvement in nasal symptoms tells you this drug is really working and that the asthma will also improve. Can we predict them? Well, I'll mention that in a moment. What about specific IgE or measuring free IgE? That has no value at all. It's not recommended. We use the baseline value and then we do not go on measuring IgE. The important thing is to see what happens clinically, whether these patients improve clinically. Could we monitor blood or sputum eosinophils? No, very limited. What about other biomarkers? No. So none of these are necessary. You just need to be a good, thorough, systematic, and continuous physician to the patient. The nice thing is that when patients respond at 16 weeks, they tend to continue to respond. So you can see the left hand in this study, the persistency rates were very high, 91% for patients who responded. And those that hadn't responded at 16 weeks, it was very unlikely that they were going to respond. They tend to persist. So for most countries, and certainly our practice, it's a 4-month trial. And if we've got a marked or a complete response, then we would continue treatment. Otherwise, we would continue stopping them. Now, this is data from a registry where patients were assessed for exacerbations over 24 months. And you can see that the rate of exacerbations reduced over that time, meaning that by the end of the 2 years, more and more patients were free of significant exacerbations. What happens if you stop the treatment? Well, unfortunately, if we look at the circles here, there is loss of asthma control. If we look on the y-axis, you can see the duration of treatment. Now, many people who stop their treatment after only a few months will continue to be controlled for some months thereafter. But probably 2/3 of patients will relapse if they are not controlled, if their treatment is stopped. But the good news is usually when you retreat, they do come under control again. So you haven't lost ground. It is very effective against seasonal exacerbations, and this is a study from the US showing how with the orange, the omalizumab treatment in these high-risk severe asthma patients prevented the exacerbations caused by viruses. How does it do so? Well, it's been recently shown that IgE reduces the production of gamma interferon, which is very important, alpha interferon, which is very important antiviral molecule. And by giving a blocker of IgE, these viral-induced exacerbations may reduce because of improved or reconstituted antiviral efficacy. So that is one area that's been actively studied. Now, what about the other treatments? I don't have time to talk about the new treatments, anti-IL-5s, anti-IL-5 receptor blockers. The 2 anti-IL-13 molecule developments have stopped because they were not as effective as the anti-IL-5, and there's a new possibility down the road for dupilumab. Now, the point I want to make is that there's a lot of overlap in terms of the efficacy of that. But most clinicians now believe that we probably should be, in the allergic patient, should be going the left-hand side here to give 16 weeks of omalizumab treatment. And if it's ineffective and the patient has high blood eosinophils, one still has the option to trying these other molecules, other treatments which are currently being developed. So to end with then, what I've described is that allergic asthma is the most common phenotype in children and in adults, that IgE is a marker of allergic asthma and also associated with the Th2 type mechanisms of disease. I've talked about omalizumab, which is a forerunner by a long period over other targeted monoclonal antibodies. and that there's strong evidence for its efficacy and safety. And importantly, we're only beginning to realize all the advantages of normalizing patients with a high IgE. And one of the effects may be in antiviral properties. So I thank you for your attention. I'd be happy to take any questions.
Thank you very much, Professor Bettman, about this illustrative, very nice presentation. Now it is open for the floor for discussion. Any questions? Again, on behalf of the Egyptian Thoracic Society, Scientific Society of Bronchology, it is my honor to introduce some appreciation for your chair in our meeting. Thank you very much. بنختتم اليوم النهارده ان شاء الله، ويوم كان صعب على حضراتكم جميعا وعلينا. ان شاء الله الغدا هيبقى على حمام السباحه. اتفضلي.